Good afternoon, everyone, and thank you so much for joining our webinar on lost specimens. My name is Jen McCready, and I'm the Senior Program Director for the AMC PSO, and I'm so happy to have everyone here. I want to start out by sincere thanks to our subject matter experts as well as our planning team. This was truly a team effort to pull this together, and so excited that so many people have signed up to join us. I think it's going to be a really great session. So our agenda today, I'm going to get started with introducing our wonderful speakers. We'll go through the PSO life cycle, some of the background of specimen management, and then jump right into the vulnerabilities and risk mitigation strategies, applications for practice. We also have available resources, and we hope to have, as I said, plenty of time for questions and answers at the end. Please type them in to the Q&A, or once we get to the Q&A section, we encourage anyone to raise their hand and we'll be able to unmute you to ask your question as well. All right, so it is my great pleasure to introduce our subject matter experts today, and I'll be reading through each of their bios. So first, we're joined by Dr. Yael Kushner-Hare, who oversees the quality and patient safety for the Mass General Brigham Health Enterprise Laboratory Service. At Massachusetts General Hospital, she also serves as the Associate Chief of Pathology, Quality and Safety. At MGH, she also serves as the head of the Renal Pathology Subspecialty Service. Prior to joining MGH, Hare was the Director of Quality and Safety and a renal pathologist in the Department of Pathology at Beth Israel Deaconess Medical Center in Boston for 10 years. She received her medical training at McGill University and completed her residency in anatomic pathology at the Montreal General Hospital, both in Montreal, Canada. She was a Robert T. McCluskey Fellow in Medical Renal Pathology at the MGH in Boston and a graduate of the inaugural class of the Harvard Medical School Fellowship in Quality and Patient Safety, which is a program designed to train a cadre of physician scholars prepared to lead operational improvement efforts within the Harvard system and across the nation. She received her Master's of Public Health from the Harvard School of Public Health with a thesis aimed at high systems improvement. Hare holds numerous national leadership roles in quality and safety and sits on various committees tasked with quality and safety oversight and federal and state policy. Hare's main academic focus is on the role of patient safety and quality in pathology, and she has a special interest in pathology error disclosure. Welcome, Dr. Hare. We also have Dr. Rajesh Patel, who is the Deputy Chief Health Information Officer and Assistant Vice President for Beth Israel Lahey Health, as well as an instructor in medicine at Harvard Medical School. His role includes the evaluation, design, implementation, ongoing analysis, and refinement of information systems that support clinical care delivered by the health system, as well as enhance individual patient and population health outcomes. Along with VP of Technology and Innovation, he leads development of EHR Plus, a portfolio of innovation projects supporting the Beth Israel Lahey Health System strategy through custom development and implementation of emerging technologies. Dr. Patel completed undergraduate and graduate studies at Boston University in computer science and then gained several years of professional experience as a software engineer prior to medical school at Boston University. He completed internal medicine residency and chief residency at the University of Michigan. Prior to Beth Israel Lahey, Dr. Patel was Chief Medical Information Officer and Interim Chief Information Officer at Brigham and Women's. Thank you, Dr. Patel. And last but certainly not least, we're joined by Dr. Yvonne Chung, who is the Associate Medical Director of the Academic Medical Center Patient Safety Organization in Boston. Dr. Chung is also Associate Chief Medical Officer at Newton Wesley Hospital, President of the Massachusetts Coalition for the Prevention of Medical Error, and a member of the Quality and Patient Safety Committee of the Massachusetts Board of Registration in Medicine. She is a graduate of Harvard College, receiving her MD from the College of Physicians and Surgeons, Columbia University, her MPH from the Harvard School of Public Health, and MBA from the Eisenberg School of Management, UMass Amherst. She maintains clinical practice in anesthesiology. So a very warm welcome to all of our speakers, and thank you again for joining us. And just before I hand it over to Yvonne, yes, thank you, Carol. Pleased to tell you that today's presentation is eligible for 1 AMA, Category 1 CME credit. The authors, faculty, planners, and reviewers for this webinar have reported no relevant financial relationships with commercial interests. And by the end of next week, you should receive an email with a link to complete your evaluation for your CME credits. Thank you. And with that, I'll hand it over to Yvonne.
Thanks so much, Jen. Want to welcome everyone to the webinar today. So delighted that you could join us. And again, we'll, as Jen said, we'll cover the following learning objectives for this afternoon's discussion. We will start by describing the life cycle of the PSO convening and review of some of the initial steps that the Patient Safety Organization does in terms of preparing for the convening about any topic. And then we will dive more deeply into the life cycle of pathology specimen, specifically focusing on the pre-analytic aspects and quality and safety risks. We will illustrate areas of vulnerability in the pre-analytic pathology management that are in particular amenable to risk mitigation strategies. And we will review consensus-based recommendations for structures and processes to reduce risk and also improve patient safety, as well as reliability in the processing of pathology specimens. And I just want to add that the content that we'll be sharing today was really developed over a series of convening sessions held over the course of 2 years and convened by the CRICO Patient Safety Organization. Carol, if you want to go ahead to the next slide. We thought what we would do is actually start by framing, by giving the participants, you all today, a sense of the life cycle of any kind of patient safety organization convening session. And so it really starts at the very top. A problem is identified for all of us collectively to get together and meet and discuss to problem solve. And so that problem might be identified by any member organization, typically via communication with a member of the CRICO AMC PSO. Once that problem is identified as an opportunity, then further sort of background is done in terms of fleshing out and identifying the prevalence of the problem, the implications for a worst outcome, type outcome, worst possible outcome, and that is all done as part of the definition of the problem, and that's done primarily by patient safety organization staff. May involve some data mining of our own root cause analyses database. May involve some conversations, further conversations with either the member organization that first raises the concern or other member organizations, again, all in an attempt to further sort of narrow the scope and identify the question and frame the question for the convening sessions. Then thirdly, moving clockwise in this circle, then a series of convening sessions is planned. Subject matter experts from really across all of the CRICO PSO member organizations are invited to attend, typically a series of 2 or 3 convening sessions held pre-pandemic, held in person. Since the pandemic, we've had great success moving to a virtual platform for discussion and identification of and prioritization of the main patient safety risks, as well as the development of risk mitigation strategies for each of the prioritized patient safety risks. The CRICO PSO staff then takes back the content, the meat of the meetings, and really develops drafts, a guidance document, and that's really the execution piece of the life cycle. And this draft will go through several iterations amongst the patient safety staff before then being shared with PSO membership. And this includes, but isn't necessarily limited to the members that attended the convening session. We do ad hoc sometimes bring in other subject matter experts to further review and provide feedback for this guidance document. And then finally, as an end step, the guidance document is published on our website for broad dissemination and is available free of charge for download by all on the CRICO website, which is rmf.harvard.edu. And then we do some promotion, which really is the webinar that you're all at today is one of those forums by which we try to communicate more broadly so that we can get the learnings disseminated to the staff that identified the problem in the first place, and also to further provide learning for as many as we can, and to further advance patient safety and quality improvement work. Next slide, please, Carol. So specifically as it related to the timeline for the lost specimens convening, the initial convening sessions were held beginning in June of 2018 and progressing through to January of 2020. At a midpoint in the convening sessions, CRICO actually did, as they sometimes do, decide to offer further support to advance this important work in terms of identifying risk mitigation strategies and then implementing and testing them by providing grant funding over a year and a half from July of 2019 to December of 2021. And that was conducted under the auspices of one of the speakers today, Dr. Patel. In November of 2021, the task force, the convening sessions resumed and were reconvened. And ultimately, that was the beginning of the drafting of the guidance document, which was ultimately released in May of 2022. And you see the cover page of that guidance document that was ultimately published, as well as a link to a QR code that you can take a photo of or scan with your camera on your phone. And that will take you directly to the place on the CRICO website, rmf.harvard.edu, where you are able to download the entire guidance document for your own review. Next slide, please. And so the next part, which I'll provide as background before I turn the session over to Drs. Hayer and Patel, is providing a little bit of the background on the first aspect of that life cycle that I just reviewed. You want to go to the next slide, Carol, please. Thank you. We'll move to a little bit of the data analysis that our own PSO staff conducted once, as I'll remind you, the problem was sort of identified by one of our member organizations. We wanted to really do a little bit more of a dive into our own RCA, root cause analyses, RCAIE database, to determine the prevalence. And we did that by looking at all of the RCAs and then really trying to identify which ones had an element of a lost specimen as part of the problem that prompted the conducting of the RCA itself. You want to go to the next slide, Carol? Thank you. And so as you'll see here from our own AMC PSO database, now this is a database of root cause analyses that are submitted by all of our PSO member organizations throughout the country, actually. And so they are submitted, and then we are able to mine that as important aggregate data for these kinds of convening sessions, but also as a way to look at aggregate data to identify trends and certainly emerging risks in patient safety. And so what we found when the PSO looked into our own database was that 44 of our RCAs that had been submitted by the member organizations had, I'll quote, lost specimen events. And I'm quoting only because there was no specific taxonomy or category labeled lost specimen. So really a member of our staff, Kathy Zygmunt, who I want to give the credit to, really went through each one of them to read through to identify sort of our own version of natural language processing where there might have been lost specimens as part of the RCA, the root cause investigation. So we found 44 between the years 2009 to 2018. And then we further categorized them by severity. And so that's the high, medium, low, and near miss. A high severity lost specimen event, just as an example, might be one where a colonoscopy was done, a polyp was removed, but then unfortunately the specimen, the polyp, was lost before I could get to pathology. Subsequently, hypothetically, the patient presents at a later date with metastatic colon cancer, and obviously that would be a high severity, devastating outcome for that lost specimen event. A low or near miss might be one where a blood sample was collected, but then the specimen was lost prior to getting to the laboratory for the complete blood count analysis. And the patient was contacted, had to come back for a redraw. Obviously, suboptimal experience for the patient and some non-value added work on the part of the staff in processing. But the test ultimately was able to be done and the results able to be, followed through. So that might be a low severity or near miss. Next slide, please, Carol. And then once we found those 44, we actually did a further look into each one of those RCAs to try to identify common themes in terms of top contributing factors. In the interest of time, I'm not going to read through all this. You can see it here. But I would say in terms of broad bucket categories, as is often the case, communication was often a contributing factor, either a need for policy or protocol or a lack of complete understanding by the staff of an existing policy or protocol was also one of the top contributing factors. And clearly there are many, many different kinds of systems issues to work on, all contributing to, increased patient safety risk. You want to go on to the next slide, please? Thank you. And now I'm going to actually turn it over to Dr. Hare to review some of the specific case examples. You can take it away, Yael. Thank you.
Thanks, Yvonne. I also wanted to clarify, when we first convened this PSO, I think it was 2018 or 2019, we did limit the scope to anatomic pathology. So although there are a lot of lost specimens, major issues, like the ones Dr. Chung alluded to around blood draws, we did not focus on that for this AMC PSO. It was really just surgical pathology and cytopathology specimens, just because the workflow was so different. So for those of you who work in that area, we really pulled together surgeons, anatomic pathologists, surgical pathology specialists, nursing, and it was really focused on tissue specimens. So we have a couple examples of those next. So the first one was a woman who had, it's kind of shocking, a hysterectomy, and we lost the uterus. I won't read the whole thing out to you, but we lost it. We thought it was on the way to the OR. Nursing thought they brought it to the OR. We had a digital way to track it, but there were workarounds for that. And we never found it. So in this case, the patient had a hysterectomy for a benign reason. So it's still awful, but it's not like when you're resecting a tumor that you're trying to diagnose and it's lost forever. So next we have a couple of different, these are not uncommon. I mean, uncommon in our overall denominator, but in most centers, this has been reported. The second one is less of a complete loss of a specimen and more of kind of loss of the specimen because it was completely misprocessed. So this is a relatively common scenario. There's someone who's sent for an undifferentiated lesion. It's typically either lung or bone. It's either malignancy or infection typically. So the specimen has to go to many different parts of the labs, typically micro and surgical pathology, and the whole specimen was put in formalin when in fact it should have been sent fresh. And although, really not moving enough, although the primary team had communicated with interventional radiology, the proceduralist, prior to the procedure, but that message got lost in translation, and it was obviously lost in translation from the ordering provider team. So the patient had to undergo a second biopsy. These are real cases. And the second procedure was complicated by a pneumo, and he needed a chest tube, and eventually made the right diagnosis. Next. So interestingly, I think one of the things for those of you who are lab professionals on the call, we often think about diagnostic error as at the microscope. You can probably see my microscope behind me. So you could sit there and you look at it and you see the wrong thing. But many of us have reported that actually most of the problems are before the case ever gets to you. So it's either ordered wrong, it doesn't get to us, it's mislabeled, we don't accession it right, and we don't triage it correctly. And this has been reported not just by our group, it's up to 85 to 90% of cases have a pre-analytic root cause. And that's been shown again and again all over the country and elsewhere. Next. So CRICO, the AMC PSO, we got together with all these folks and we broke down the pre-analytic phases. So sorry, if you just go back, Carol, to the previous slide, we have all these different parts of pre-analytics, ordering, transport. We literally just broke those down and troubleshooted with all the different causes that were in our experience and how to mitigate those risks. So our next slides are in ordering, and then it'll be transport, et cetera. And we have on the left risks and on the right things you can do. And the document itself is actually much more detailed, and we wanted this to be less of a didactic session and more, we just a broad overview, and then we can have a good Q&A session at the end. So I'm not gonna read you the entire thing, but basically ordering is fraught. And it's fraught with a lot of detailed pieces of information, both around what the differential diagnosis is, how the actual procedure is being performed, how that changes in real time in the operating room based on what the surgeon finds or based on what's possible in the interventional radiology suite. And then what actually has to be done properly for specimen handling, labeling, and handoff. And you'd think that that would be pretty straightforward, but in anatomic pathology especially, it's not straightforward at all. And it can change based on what people find. So we had some risk mitigation strategies, which included standardized requisitions, decision support tools to prompt clinicians on the correct test and collection requirements, and just better bidirectional communication. Obviously, if you could have a fully interfaced electronic ordering system like Epic Beaker, so the lab information system and the EHR, that's better, but not all of us can afford to do that. And obviously, you have to balance creating a hard stop requiring information with allowing clinicians, busy clinicians, to put in orders they need to put in without making them completely crazy with all your requirements. Next slide. Collection and labeling is a major issue. Mislabeled specimens, not just based on site but patient name, is actually a big deal. And unlabeled specimens happens more than you'd think, which the lab has to reject, which especially in pediatric patients is really hard. And so, one of the risk mitigation strategies we came up with was a timeout. There are surgical timeouts in the OR. So we suggested a specimen timeout, sort of around matching the patient to the rec, matching the rec to the specimen, and then also just making sure you have the correct number of specimens. Often in the OR, you don't have good anticipatory capacity around what we're ordering. So you're going in for, let's say, a lung cancer removal and a lymph node dissection, but you don't know how many stations or how many specimens you're going to get to depending on. And so you could easily lose a critical part of a specimen that affects the staging of the patient. Next slide. So around transport, this is a major issue. So for those of you who are responsible for a large number of, especially ambulatory care sites, but also within the operating room, we often contract out with couriers. And we do that within the CRICO system at many of our hospitals. And there are a lot of issues that are fraught with that around, points of contact not being warm handoffs, just the timing of when specimens are procured versus when they're picked up versus when they're dropped off, and all the different handoffs that can occur there. We also need to have specimens be covered, so you can't see the names and check because of PHI, but actually it would be better and easier if you could. And many of the ambulatory care sites are not on the same EHR, depending on how affiliated they are. Think of like a GI endoscopy suite or a dermatology practice or something that's quite high volume, but in the periphery, and how that could be lost in translation. And so we suggested a bunch of different things. Obviously, barcoding, it's not perfect, but if you can do it from the point of collection to the point of accessioning in the lab, that's ideal. Many of us only start barcoding things once we receive them in the lab, which misses the entire pre-analytic period, because we don't own the practice, right? We've contracted with some practice that we said we would sign out their cases, but we don't actually have the capacity to label them at the point of care. So that's a problem. If you're able to extend that or at least create that with your couriers, that's better. Interoperable AHRs, obviously, yes, I leave that to Raj, but ideally, yes, but not all of us can snap our fingers and do that. Interestingly, around contracting, many of us sort of have these vended services with couriers, and the contracting oversight is totally separate from the lab oversight. And so the contract is made, and there's not a lot of governance and monitoring of those quality metrics, to make sure things are happening and tracked and all that. So that was a recommendation we had. And consider actually, a specimen transport team for oversight if you have a huge network. And next slide. Sorry, I'm pressing the forward button. Yep. So around accessioning, triage, and clinical information, I think this might be the last bucket. Really interesting. This is when the specimens actually come to the lab, right? When they get to the lab, what do? So when they get to the lab, there's a staffing pattern. Sometimes they come very late in the day. Imagine there's someone making rounds of the entire city of Boston, and they drop off a huge batch at 8 p.m. Well, by then everyone's gone home, or there's one person who's also manning all the specimen machines, right? So it's very batched, very manual. And there's someone sort of picking patient names from a huge drop-down list. Some of the patient names are similar, some of them are handwritten. We have all kinds of contracts with people, so it's quite fraught. So we one of the mitigation strategies that we recommended was developing some kind of anticipatory capacity with high volume areas, like, where you could reconcile, let's say, a GI endoscopy suite or dermatology, where they send you a list somehow of the patients who are biopsied, so that at the end of the day, you can make sure you receive those. Obviously, that's a lot of work. Develop and enhance standard processes for this, and also just create better anticipatory staffing capacity around these kinds of issues. And then, interestingly, many of the labs we spoke to, not as a preventative measure, but as sort of a safety net, had policies around saving their trash or saving other items in case things were lost. They had a capacity to look for them. And so the other thing, the last thing we recommended was more for that lung cancer patient, was around creating safety nets. So if there's a specimen that's not only meant for surgical pathology, how do you flag those? And how do you make sure they don't just go right onto the processor? Like, is there some kind of check for specimens meant for microbiology or molecular testing or other specialized testing in these very difficult to get specimens, or do they just come in with all the other specimens and it's hard to notice? Next slide. So this is a good transition for Dr. Patel. One of the great transition points was many of the issues that I mentioned are really owned by an incredibly diverse group of stakeholders. And that's one of the reasons why people have trouble managing them in these large systems, right? Like everything I mentioned, if it was just lab, we would have done it. Or if it was just IT, it might have been done. But it's lab and nursing and IT and surgery and a lot of complex partnerships and bidirectional communication. So I think that's why it's really been a tough thing to resolve. And that's where Dr. Patel and CRICO's grant really comes into play. And you'll be happy to hear some of his recommendations around building a multidisciplinary team to make things better.
Thanks, yeah, and I will say, to build on your comments, I while I do take care of patients, I'm generally the IT guy in the room. So it's always, many of you may be asking, well, how did you?
We just can't hear you.
Oh, sorry about that. Is this better?
I can hear him.
I can hear you fine.
Yeah, I can hear you too.
Okay. Just let me know if there's any issues, but I think the way that I got involved in this project is perhaps the way many of us get involved in specimen loss issues. There was an event at my institution, and one of the suggested interventions was an electronic tracking system. To Yael's previous point, what I quickly realized when sort of after being charged with the development of an electronic tracking system for specimens at my institution was that this is much bigger. This problem is much bigger and goes way, way, way beyond simply a new electronic system. And so, as mentioned, want to talk a little bit about the team building and team organization that some of you might consider if you're looking to tackle improvement efforts in specimen loss. So next slide, please, Carol. So, I think we all realize that we come from different places, right? Large academic health systems may have significantly more resources than smaller community hospitals. But however we're organized, you need an agile, tightly integrated core team working on a project like specimen loss. That team should probably be about 3 or 4 people. They should be sort of empowered by hospital leadership, and from our experience with the CRICO grant, include at least a dedicated project manager, a leader in the laboratory space, a leader in the information systems space, and that's not just self-serving. It's because, you know, all of these systems, as you know, and as was mentioned, are tightly integrated to the electronic clinical systems, and in cases where they're not, that's often where there are challenges in this workflow and where risk presents itself for specimen loss. And then finally, you would ideally have a leader in the hospital operations domain. The first step for any group, any core team that's going to work on a project like this, is to actually assess current state. And preferably you do this quantitatively, but certainly any way possible is the way to move forward here. And you really want to do this for a couple of reasons. First, it really helps the core team sort of identify the clinical area that your organization may struggle with most in terms of specimen loss. It will help to prioritize what clinical area you may want to tackle first. And then the information that you gather can be used to engage your stakeholders as you move forward in this project. And so, you know, you can use safety reporting systems, and that's what our project did with our CRICO grant funding. We reviewed 1 year worth of safety reports in our safety reporting system, RL systems, to try to quantify exactly how many specimens were we losing on a week by week or month by month basis. And we tried to quantify not just absolute losses, but also near misses. With each event, we tried to categorize exactly where in the workflow the loss was, and to Yael's point. We were able to reinforce very, very specifically and with local data that the pre-analytic phase is where the vast majority of our loss was. And these data were presented many times to stakeholders all over our organization, outside our organization, to help reinforce and motivate moving forward on this work. In terms of the next step for the core team, once you have some of that data, you kind of have some ideas around what areas you want to attack. The next step, of course, is to sort of build out both a governance structure and then a team structure. And those are some of the pieces I'm going to talk about next. In terms of governance, certainly what we learned was we really needed a fairly broad engagement from hospital and health system leadership. We involved our CMO, our CNO very closely, as well as lab leadership, both in the AP and CP spaces in our case, because we did want to try to attack some components of the CP workflow as well. Next slide, please, Carol. After building up an executive sponsor team and integrating closely with them as a core team, reviewing exactly some of the data that we had gathered and some of the areas that we wanted to attack first, we started to develop local teams. And what I mean by that is that, you know, as we collected data, we realized that, you know, our project needed to be focused in not only a variety of sort of clinical areas, but also in a variety of operational areas. And so we had workflow remediation processes that we were working through in interventional radiology, operating room, endoscopy. And Yael had mentioned many of those, things like timeouts, for example. We also realized that we needed to reorganize how our transporters were both managing specimens, but also where they lived within the organization. Making them a part of the lab was something that made sense for a variety of different reasons. It helped in terms of the training and knowledge that those folks can be empowered with, and really helps to kind of cement in their minds the importance of the work they do in transporting specimens specifically from these clinical areas back to the lab. So as we established a variety of these teams, we realized that doing the work serially would be challenging in terms of timelines. We'd probably have a decade-long project. So it's worked slowly, carefully to try to run them in parallel. Had some challenges with the COVID pandemic, but was ultimately, think we're able to implement a variety of changes in the labs, as well as several clinical areas, about 3 clinical areas, in concert with one another or in parallel. And all the while doing this, it was very, very important for us to kind of constantly loop back, make sure we were sharing successes with folks, making sure to keep folks engaged and bought in to this process, that we didn't present the efforts that we were doing and then sort of walk away from them for 6 months and not kind of loop back and share what we had accomplished in all of the other groups and all the other areas. Next slide, please, Carol. This is an example of how we sort of organized. As you can see, that core team is in the rightmost section on the yellow highlight. So project owners, local leads, subject matter experts in risk, quality, and safety and transport were sort of a core team. Executive leadership all the way to the right over them. And then we divided up into a variety of different work streams. Procedural workflow standardization had sub-teams in the OR, in IR, endoscopy, for example. We revamped the way quality and safety was organized around this project to integrate them better with the staff within each of the areas that we were working closely with. I mentioned transport and logistics and how they were reorganized. That's a separate work stream altogether. Lab efforts, which included facilities changes, was organized in a separate work stream. So any organization thinking about this will have to sort of design their teams flexibly in a manner such as displayed here. And next slide, Carol, I think shows just an example of some of the workflow standardization that we went through. So this is an example of the work that one of the work streams, one of the subgroups would do. They would essentially, as we had described it, the core team would help to establish a local team. That local team, along with process improvement team members, would do a workflow mapping, identify vulnerabilities in their processes, try to develop a remediation plan. Some of that plan could be a standard operating procedure. Some of it could be an EHR change. Some of it could be part of it could be the electronic tracking system that was the original impetus for this work. And then next step was to implement sort of a remediation and training plan for the local project. And then, of course, we'd continue to refine this over time and make sure people would, for example, continue to adhere to standard operating procedures when they were developed. Next slide, please, Carol. So I think overall, in terms of take-home points, if you don't mind advancing to the next one. I think we highlighted the majority of reported specimen loss happen in the pre-analytic phase of specimen management. And although the reported rates of specimen loss of both retrievable samples and irretrievable samples are low in absolute number, they're likely high in relative number, they're likely high in absolute number given the large volume of specimens that are moving back and forth at any given health system. Not only are the absolute numbers high, but there's underreporting of loss, as we all know, due to some of the limitations of safety reporting systems. One of the other key points that sort of I learned from this is that you of course cannot change what we don't measure. Realize the imperfections of the safety reporting systems that we have in place now, but any project has to start with this analysis so people can get behind it, a project, and continue to go back and look at exactly how much have you actually had any improvement from your base state. Long-term tracking systems could help in terms of measuring, but as Al mentioned, these are expensive, complicated systems to implement, and not all health systems have that capability. And finally here, ownership of this work is highly multidisciplinary. It involves the lab, IT, quality and safety, clinicians, operations. And so rather than diffusing it across dozens and dozens of people, we recommend really establishing a very small core team that then goes out and develops tentacles in each of the departments or areas that are necessary, and then build sub-projects to do this work. It is very, very challenging long-term work, but if you keep at it, certainly can make a dent. And our project continues on as the PSO team knows, beyond the grant. And so hopefully we will have a chance to present some of the ongoing findings from that work at some point in the future. I think next slide, Carol, please.
Thank you both. This was great. I love that visual, Raj, of the workflow. I think that's so great. We do have a couple questions coming in that I will read out loud. And Carol, if you want to just go to the next slide, as people are sort of thinking through their questions and getting up the courage to raise their hand, which please do so, and we can unmute you. I would just encourage you all to download the full guideline. It has everything that we talked about today, as well as some great further detail for anyone that is interested in this topic. It looks like Yael answered one in the chat, but I think I'll just read it out loud because this is a nice question. Julie asked, can you provide your thoughts on disclosure of lost specimens? Is there a standard process or a best practice that you can discuss? And Yael gave a great resource. I would encourage all to check that out.
Yeah, I mean, it's hard. It kind of depends on the level of harm, but if it's an irretrievable specimen, or sometimes a retrievable specimen if a patient needs another biopsy, we definitely disclose those. We typically do it in conjunction with the treating clinician, so it's a collaborative disclosure. And actually, we let the patients guide us. So typically the treating clinician or the proceduralist will do it, the ordering provider, and they'll offer to the patient for the pathologist to participate, and depending on whether or not, what the root cause is. So, and we wrote some guidelines for that maybe like 5 years ago in association with one of the anatomic pathology national societies. But it's very local. It depends on your local process, and if it is a very harmful one, like a loss of an irretrievable specimen that might affect the patient's ultimate outcome, that's something you should discuss with your local quality and safety leaders and your sort of department chair or wherever before you move forward. Just because there are communication and resolution programs and all kinds of things that might come into play, it can get complicated. But yeah, it's a good review, not to again self-cite, but it includes all those data about resources, including Macrame, which is a fabulous Massachusetts resource for those of you thinking about at a high level, thinking about implementing programs around disclosure.
Thank you. And second question that came in, is it appropriate to track who's involved when a specimen is lost, similar to a surgeon's complication rate?
I'll just keep going. I mean, yes, I think it's always appropriate to track all information related to a safety event. What you do with that information is really important. Like, so we track all errors in the lab, and we definitely track them back to technologists, to pathologists, and to whoever. The key is not to be punitive if it's a one-off, right? Like if you're looking for trends, and that gets to the point around just culture of the balance between individual responsibility and sort of systems issues. So that's when you do like a proper RCA. I would suggest the RCA squared framework. Maybe I could put that in the chat, or someone could put that in the chat, but that's a good balance for we use the substitution test here, meaning like, would a person with a similar background and training in the same situation have made a similar error? And in these cases, many, many times it's a systems issue, but you can see sometime where it might be both, right? Like, it's not good that, like in that first case, it wasn't good that the nurse could check in the specimen somewhere totally different than where she was supposed to check it in. Like, the computer shouldn't allow you to check it in at a place you're not at, right? So that's bad, but that's a systems issue. But on the other hand, she shouldn't have done that. So that's bad too. So I would track both. That's the balance. And then if it becomes an issue where like there are outliers in terms of performance, then it becomes more of a coaching issue than a systems issue. But ideally, you want to create systems that make it easy for people to do the right thing, and where, you know, you're really only detecting outliers by looking at the who question, and you're not sort of whacking people for failing within very difficult systems to do the right thing. I mean, if I would definitely. We joke in our histology lab, like I have slides here, and the numbers are, they're tiny, and they're all sequential, and they're tens of thousands of them. I would definitely mix them up if I worked there, without barcoding. So that fails the substitution test.
Great, thank you. And I would encourage all to check out the chat. People are putting in some great resources to macrame, IHI, so I would encourage people to check that out. Switching gears a little, to circle back on the recommendation of using the timeout process. Were you able to partner with surgeons or other role groups to improve adoption and successful implementation?
I can maybe speak to that a little bit. So, I will say that, I think a lot of the work around timeouts or debriefs was actually, in our ORs was done locally. I think we surfaced that it wasn't happening routinely. And that local team, as I described, really took it upon themselves to, one, sort of start with the policy, start with a standard operating procedure around some of this. So really kind of put this stuff down to paper, that it has to happen at the end of each case. Here are the various elements of it, and then developed an entire training around it. There's a electronic sort of video training around it that all nurses and providers are now working are working through and getting now as part of their standard sort of onboarding, and that really has changed the culture around that timeout, the specimen timeout or debrief as we call it. So I think that certainly surgeons were a part of it. But multiple clinicians, multiple roles, including the nurses, really were critical in doing that work.
And I think that leads nicely. Let me know if there's anything you have to add to this next question too. Do you have a recommendation on how to build stronger debriefing systems that include specimen reconciliation into universal protocol debriefing practices? It's a tough one.
Yeah, I mean, I think part of what folks have been sort of looking for is there a way to do this in the like electronically? I think, and I think that I think we need to provide the systems to actually perform the reconciliation in the sense of like you have all of the data available to you, but ultimately we're still going to have sort of a process component to it and a checkpoint component to it that that is sort of unavoidable, and that a sort of process improvement effort needs to be instituted, rather than some of sort of like what Yael was talking about, the sort of hard stop components that some may think are sort of an easy answer to this. I think Yvonne, you have something maybe to add to that one.
Yeah, thanks, Raj. Yeah, I was just going to say, I think, as you're saying too, echo the comments about this being somewhat partly cultural, partly hardwiring, and making, like the Staples button, easy to do what we think is the right thing. I might suggest, leveraging or connecting with, maybe collaborating with is probably a better word, your colleagues in that perioperative space, because particularly for OR procedures, where a specimen is being collected, you could certainly think about trying to build it into the sort of while we're closing, the latter part of the procedure debrief. And I know that's not universally adopted, but more and more institutions are starting to move to that as sort of like a mirror to the pre-op huddle or the timeout. So that's one area. And then I think also, working with quality and safety and risk colleagues in your own institution to try to build those bridges. And then finally, I guess the comment that Raj just made about there needs to be some kind of reconciliation. So with the specimens that leave the OR must be matched to the specimens that are recorded as being received in the lab or pathology. I think those are sort of the components to start to look at least. And there's going to be some, local nuances, I think, that are going to drive everybody's own improvement efforts. I think above all, it's trying to design a system, or refine a system so that in a way that it's workable for people, and you're not adding extra burden, or what's perceived as burden, unless it's also perceived as being valuable, right? Because that's how you get the engagement and the buy-in. And people at the end of the day, if people don't believe in it, they're not going to do it, no matter how well the system's designed.
Great, thank you. And Bessie asked, with the current staffing challenges, has this impacted your work? And also, what has been the most sustainable aspect of this work?
Yeah, I'll jump in there. I do. So yes, is a simple answer to that. I would also say that sort of COVID impacted this work. So, this grant was funded. Well, the work started before the grant, just to give folks a little background, at least, in my work. And the grant certainly gave us a great deal more resource, and then COVID hit. And essentially, we had to put a lot of work aside for the better part of 2 years. So both staffing and global pandemics presented challenges. In terms of what has been sustainable, despite all of those, we reorganize, or are in the process now of reorganizing how transporters, again, are trained, what department they report to, and are they now sort of narrowly dedicated to specimens, or were they previously transporting patients one moment, specimens another moment, something else the third moment? So that is a sustainable change. One other change that was sustainable in all of this is the realization that there was a very large number of drop-off locations, some of them unmonitored, and that needed to change. And in particular, there were facilities changes made in the ORs to make it easier to drop off a specimen to the frozen rooms, and the work to remove some of the unmonitored drop-off locations in the ORs is happening now. So that's, again, a sustainable change, because the single point where the drop-offs are happening, no more unmonitored areas in that particular location. And there's other changes planned throughout the organization to reduce the number of drop-off locations more globally. There are some IT changes. We are very, very, I would say, close to piloting a barcoded specimen tracking system, as Yael had alluded to now, and that is another highly sustainable change that has come from this. And then I would add the debrief piece now. it's really become ingrained in the culture. And I would say nursing is taken this on more than any other role, at least in the organization that I'm talking about here, and really champion this. And it's just become a very, very core part of every case in the OR, and that needs to be replicated in other clinical areas, for example, endoscopy, perhaps, but that will come with time. And there's a wonderful model, wonderful template from the OR to reuse in that.
Great, thank you. We have about 3 minutes left, so we'll make this the last question. Provide additional information on unmonitored location. Were these just drop box locations?
Yeah, there's different configurations of these. There are, for example, refrigerators that you can just open, close, drop off, and there's a pickup schedule that is either known or unknown for each of the refrigerators. There are windows areas that are also, sort of more closely physically located, in the lab areas that are unmonitored. There's bins oftentimes sitting outside of those. And then, I would say probably the biggest challenge would be, we have a very sort of large distributed network of clinics, and all of you do. And oftentimes there's here's the specimen bucket. Those we're never going to have monitored. But you want to sort of think about how can we secure those a little bit instead of having a sort of open box there. Is there a way to sort of have the box, locked in some way, something that's only available for the transporters to access? You scan the samples as they go into that box through a slot. So those are some, sort of 3 different examples of unmonitored drop-offs.
Great, thank you. And Shirley wanted to get in one more, so I'll read this one. And Shirley, if you wouldn't mind just slowly clicking through, I encourage people, we have some other educational opportunities coming up. So keep an eye on the slides for those barcodes. But last question, any recommendation for areas that do not have barcodes?
Yeah, that's a great question. I mean, there are a lot of projects that can be done outside of barcoding. It's just a huge number, right? We've already gone over, a bunch of them, and I think, again, just starting with monitoring your current situation. I would say at our organization, it was not clear that we were actually looking at this quantitatively, qualitatively.
I would just even modify that, say it was clear that you were not.
It was clear. It was 100% clear that we were not. You're right. Monitoring these.
No, because no one does.
Because that's 100% true. And from that, you're absolutely going to get process improvement work that can be done to mitigate these problems.
I would say most people don't have barcoding, right? Especially from ambulatory care. Like the vast majority of our AP specimens come from the ambulatory. They're small biopsy specimens, they're prostates, they're derm, they're GI, and they come from they come from private clinics or like small offsite clinics. And they all look the same, and they come in massive batches, and you need to understand where your risks are, and barcoding is not a fix all.
And that's, I think I tried to lead with this, but want to just make clear the tracking work that we're doing now is last, right? We really needed to do all of that other work, that workflow analysis, the gap identification, the process improvement, as Yael talked about, and Yvonne talked about first, before we can even then layer in a tracking system. You're still going to lose. You may lose samples even with barcoding, even with a tracking system. You may be able to identify them a little bit earlier, but there's still certainly the opportunity for loss if you don't have good transport processes between 2 different areas. And so definitely think all of that work is a precursor to a tracking system that could come later.
Can I just chime in for 1 second? Just to say, I think barcoding, to me, the subject matter expert here as like the sexy, high tech, solution that I think seems so attractive. But everything that Ellen and Raj just said, in the absence of, say, the resources to be able to even think about that, I'd recommend just going back to your team and saying exactly as they said, let's work through the process. So sketch it out on Post-it notes, what's the process and how can we be more reliable in tracking to, as best we can, assure that what's leaving the collection place, whether it's your ambulatory office or whatever, matches what arrives within the lab and then gets to, the place where the test is going to be conducted. I mean, I don't know if that makes sense to you, Yael and Raj, but
I mean, I think we're over, and a lot of our specific recommendations are in the report. So like you should, but there are 2 questions on reference labs. Maybe I know we're over, but that's a real problem. It wasn't within the scope of this PSO, but it's a massive problem, reference lab testing. And what I would say is that for someone asked about flow and someone else asked for something else, like we call them send outs or frequent. So I put a reference in there for you, again, shameless self-citation, but it's a real, bottom line, if you don't want to read it and you don't want to do anything, is the way you treat the ambulatory care and all the pre-analytic people for this process, you just include the reference lab stakeholders in that process. So there's going to be people like that are like the pre-analytic from Quest or from NVDA or from wherever you send your testing. And those folks need to be involved, and you need a tracking system. You're not going to have the same EHR. None of that stuff is going to apply. The barcoding is not going to apply, but all the process stuff needs to apply, and there needs to be monitoring and ownership. And it is a major problem that was not within the scope of this PSO, just because it's a totally different group of stakeholders.
Thank you. And thank you all so much. I realize that we are 3 minutes over. So I want to really thank you guys for staying on the extra time to get in those last few questions. Really appreciate everyone's time. And for those that hung in there, look for your email to complete the evaluation and receive your CMEs. And thank you so much, everyone.